it's Elizabeth, and I have a patient concept map here to show you today, and it's covering asthma. Let's take a quick look here at the patho. So asthma is considered to be a reversible airway obstruction, and it results in acute episodes of obstruction, and it is triggered by inflammation and causes bronchospasm. A little closer look here. So these are the bronchioles, the larger airways, and it's supposed to be nice and wide open so that we can pass air in and out easily. But sometimes when we're having an asthma episode, some sort of a trigger causes constriction of the airway, so now the airway is narrowed. And then on top of that, we may also have mucus secretion. So now we have a narrowed airway with mucus secretion, which, as you can see, the difference between here and here, that's quite a difference as far as airflow moving through there. So this is a hypersensitivity of the airway that causes excessive inflammatory response. White blood cells in the lower respiratory tract, eosinophils, which are allergy triggered, and neutrophils. The inflammatory response releases chemicals such as histamine and leukotriene, and those are common chemicals that are released in allergy. And then this causes bronchoconstriction, so constriction of the bronchioles, the airway tubes, and then mucus production. Inflammation, an increased number of mucus-producing cells, which leads to this issue that we have up here. So this is usually brought on by triggers, and different people have different triggers, but some common triggers include allergens, so just outdoor allergies may be to blame. Cold air can trigger people, like especially I feel like in the winter months, kind of flares up asthma. And then aspirin and NSAIDs can trigger some patients. Exercise, some people have exercise-induced asthma. GERD, so gastroesophageal reflux disease or heartburn. We can have reflux that kind of comes up into the esophagus and kind of spills over into the airway and causes chronic asthma problems. And then upper respiratory viral infections. So some patients that have asthma, they may not really have to use their inhaler or have any problems until they get a viral upper respiratory infection, like a cold or bronchitis or the flu or something like that, and that triggers a asthma exacerbation. Asthma is thought to have a genetic component, so you might see that it can tend to run in families. It's most common in childhood and typically resolves into adulthood. Now, occasionally adults will have asthma, but typically it's more of a childhood disease and resolves into adulthood. It's a chronic condition with exacerbations. So it has a chronic component, which is treated with daily or controller medications to try to reduce exacerbations. And then there's acute exacerbations that are treated with rescue medications, and we'll talk more about that. Okay, so some assessment findings that you might have for your patient with asthma. They're going to have episodic, so episodes of dyspnea, shortness of breath, wheezing, when air is trying to move through those constricted bronchioles and that mucus, chest tightness, coughing, and tachypnea, so an increased respiratory rate. They're going to have increased mucus production, so they may have a productive cough. And then they may have retractions, using those accessory muscles to breathe, and nasal flaring, especially in like children and infants. These are some signs of, they're in trouble, they're having some respiratory difficulty. Symptoms of asthma are often worse at night, so they may have just exacerbations that just really occur mostly at night. They may have no symptoms at all when not having an exacerbation. So if their asthma is well controlled, day to day, you may not even know they have it. But they may have chronic changes due to frequent exacerbations, such as a barrel chest, which is just an expansion of the chest due to chronic air trapping. So that is something we do see in our asthma patients. Okay, we'll move over here to tests. Arterial blood gases We might have a decrease in our arterial oxygen, so our PaO2, and normals typically 80 to 100, but please use whatever textbook you have to determine the normals. And then increased arterial CO2, so PaCO2, carbon dioxide. 35 to 45 is the normal that I know, but like I said, check your textbook. And these labs for an ABG are indicative of respiratory acidosis. Okay, and then they may have elevated IgE levels and high eosinophil levels. And so this is a breakdown of the white blood cells, and it just basically kind of tells us that there's an allergy component. So they might have these higher levels. And if they do, we can treat them differently. So that's important information. And then pulmonary function testing. So we have them do certain breathing exercises. We do it with and without a bronchodilator medication to see if they have improvement. We do chest x-rays, and this just kind of helps us look for an acute infection. And it also helps us to look for chronic changes, such as a flattened diaphragm, which can occur whenever we have air trapping, too much air in the lungs, which kind of flattens out the diaphragm. And this kind of also has to do with that barrel chest. And then in patients with asthma, we also use the peak expiratory flow meter. And so this is a device that we breathe into, and that, we give it a good breath, and that kind of tells us how much lung volume we have at that time, and that will help us to determine how well controlled our asthma is. So we don't always use it every day in patients that have asthma that's well controlled, but in a patient who has poorly controlled asthma, we might do the peak expiratory flow meter to just help us determine what we need to do that day, because we may be monitoring it very closely, and depending on what their peak expiratory flow rate is, we might have to increase their asthma therapy, their medications that they're taking. Okay, let's go over here to interventions. So we have an asthma action plan, and that was kind of what I was leading into with that peak expiratory flow rate. There's different levels, so we might have green, yellow, or red, and it's based on your peak expiratory flow meter results. If you're green, you're good to go. If you're yellow, you might need to use your inhaler, and then kind of proceed from there. If you're red, you might need to first use your inhaler, but then maybe you might even have to end up getting on steroids or going to the ER, just kind of depending on how you're doing. Each person's going to have an asthma action plan that's devised by their provider. And then we have controller versus rescue medications. And controller medications help us to keep our symptoms under control, and there's something that we take every single day to keep our symptoms under control. We do use a step therapy, so if a patient has mild asthma and they hardly ever have exacerbations, we may just have a rescue inhaler, and that might be all that patient has, so they may not have these controller medications. But if they have frequent exacerbations, or they've had frequent exacerbations in the past and they have more severe form of asthma, they may be on these daily controller medications. And sometimes we step up their therapy or step down their therapy depending on how they're doing. So for controller medications, we have inhaled long-acting beta-2 agonists, and we'll discuss that more here in a moment. We have inhaled corticosteroids, and then we have leukotriene modifiers. Remember I said that leukotrienes are released in response to allergies and things like that, so this medication helps to reduce that. And then we have rescue inhalers. So when we're having an acute episode, we're going to use our rescue inhaler. And those are short-acting beta-2 agonists. We also use inhaled anticholinergics for rescue, and oral corticosteroids, or steroids, glucocorticoids, usually like prednisone, something like that. And then we may need to use oxygen. So we want this patient's SAT to be greater than 95%, or 95 or greater than 94, so 95% or better. And if it's not, we're probably going to give them some oxygen. So this is an example of a peak expiratory flow meter, and this is one as well. And each patient will have their, zones that they follow. So controller medications, long-acting beta-2 agonists. So beta-2 agonists are sympathomimetics, or bronchodilators, so they help open up the airway. Okay, and the long-acting ones are controller medications such as salmeterol or formoterol. And then we have inhaled corticosteroids such as fluticasone, mometasone, budesonide. And I try to always tell my students, if it ends in O and E, this is the one you have to wash your mouth out with. It'll say, you know, like you might have a question, which inhaler would you teach the patient to wash their mouth out after using the steroid inhaler, because that is the most risk for developing thrush, side effect of thrush, which is an oral yeast infection. And then the other controller medication is leukotriene modifier or leukotriene inhibitor. Montelukast is the name for that, and it's got leuc, like leukotriene, and that just helps to kind of calm down some of those things that are released in allergy. And then we have rescue medications such as the inhaled short-acting beta-2 agonist, bronchodilator. It's a sympathomimetic, and what that means is it stimulates the sympathetic nervous system. So the thing that happens, that goes off in my body when I see a bear, sympathetic nervous system, my heart rate goes up, my lungs open up, I'm ready to go, I start to like get a little shaky and a little anxious. So those are the effects of short-acting beta-2 agonists. So if I take my albuterol, my heart rate's probably going to go up a little. I'm going to have my lungs open, which is what I'm trying to do. And then I may also have side effects such as shakiness and anxiety. So those are common things that happen with medications such as albuterol, short-acting beta-2 agonists. And then we have inhaled anticholinergics, and anticholinergics dry up mucus, okay, and they end in ium. So ipratropium is one, tiotropium is another one. And then oral corticosteroids, and steroids end in O and E. So prednisone and methylprednisolone, those are common ones that we use. Okay, that's our interventions we're going to do for patients with asthma. And oh goodness, and then we'll move over here to extreme. So extreme cases are like severe hypoxia, so extremely low oxygen saturation or even blood oxygen levels, and we might see our patient might be cyanotic with that. And then something called status asthmaticus, which just basically means that they are having an asthma exacerbation that does not resolve with typical therapy. So I'm having an asthma exacerbation, I use my inhaler, I use an oral steroid or an IV steroid, and I'm not getting better, okay? And this patient might need to be intubated. This can be very serious. And we may have a sudden cessation of wheezing, which just remember that if we stop wheezing, that might mean complete airway obstruction. So if it says clear lung sounds, well, that's good. But if it says wheezing, and on the next auscultation, no wheezing, you know, that might mean we're having like just a little less, quite a bit less air movement. And then death, obviously. I mean, people die from asthma, unfortunately. So that's another one. Okay, extreme situations. And now we're going to go over here to nursing diagnosis. The big one here is impaired gas exchange. We're having trouble getting that that gas exchange. Okay, teaching. What are we going to teach these patients? We are going to teach them to avoid their triggers. Each patient might have different triggers, but they might have some things in common as well. So triggers could include allergens. So sometimes it's outdoor allergies. Dust mites. So if our patient's got, you know, dust mite allergies, or if they just have allergies in general with asthma, we're usually going to recommend that they wash their sheets in hot water on a pretty regular basis and use a mattress protector so that they don't have so many dust mites in their bed where they sleep, where they spend a large majority of time in one spot. And then cockroach excrement is actually an allergen that can trigger asthma as well. So if they're living in poor living conditions, we need to try to get that remedied so that way we can treat the underlying issue. Other triggers might include smoking. And I know you're thinking, my gosh, somebody with asthma smokes. Pretty common, pretty common. So if we can try to get them to stop doing that. And then inhaled irritants, another thing like just work exposure irritants. Somebody works around grain dust or paint fumes or things like that. And for some people, that's, you know, that's their life. And so it's difficult to try to get them to avoid it. And then smoke from fires is another thing. So maybe don't go to the bonfire if you have asthma and it triggers you. Another thing about allergens is like recommending that people don't sleep with their windows open, especially like in the spring or the fall when their allergies are most triggered. It's nice out, you know, you'd like to sleep with the air coming in, but it's just not recommended. And then avoid cold air if that triggers your asthma. So going out in the cold winter, you know, that can be a trigger. And then aspirin and NSAIDs, we said that could be a trigger. So like ibuprofen, naproxen, things like that. Exercise, I don't necessarily want you to avoid exercise, but I want you to have a plan if you're going to exercise and you have exercise-induced asthma. So like using your albuterol inhaler before you exercise, you know, that might help to open up your airways so that way you can tolerate exercise. Trigger of GERD, gastroesophageal reflux disease, you might need to take medication to treat that to get your asthma under control. And then upper respiratory viral infections, which we can help try to prevent those by washing our hands, avoiding crowds, and getting vaccinated. So that's a way that we can avoid triggers. Obviously, we want to avoid smoking if at all possible, and then teach proper inhaler technique. So know what you're going to do to have your patient use their inhaler. So most of the time they're going to recommend using a spacer, and that goes on the tip of the inhaler. And you're going to put that on there, and then you're going to shake the inhaler, exhale, and then put the spacer in the mouth, squeeze the inhaler, and then inhale through the spacer. And if the spacer starts whistling, that means we're inhaling too rapidly. Okay, so we need to slow that down, a slow, steady breath in, and then we're going to hold our breath for a few seconds, and then we're going to exhale. So that's one puff, okay? That's how we use our inhaler. So that's just a little bit about asthma there with our patient concept map.